This conference will now be recorded.
Okay. So now we'll go in detail about the laryngeal cavity and the remaining part, that is blood supply, nerve supply, lymphatic drainage, and applied aspect of the larynx. Okay. So you know about the laryngeal cavity. It extends from inlet of larynx to the lower border of the cricoid cartilage. See, this green color arrow is the inlet of the larynx. So it is bounded in front by the epiglottis, on either side by the area epiglottic fold, behind by the interarytenoid fold of mucous membrane. Okay. So it is bounded on each side by the folds. Will you identify the folds here? Okay, what is the name of this fold? First fold, you can answer in the chat box. You can use the chat box to answer. What is the name of the first fold here? Yeah, good. It's airy epiglottic fold. The second fold here is the, what is the second fold? Yeah, it's vestibular fold. And the third one here, you can see the third one is the vocal fold. Okay, good. I got a good response. Okay. So now you can see the three folds in the laryngeal cavity: airy epiglottic fold, vestibular fold, and vocal fold. This is the interior of the laryngeal cavity, what you are seeing. Okay. Now the space between the vestibular fold and vocal fold, you have a sinus here. This is called as the sinus of larynx or ventricle of larynx or sinus of Nargagini. Okay. So it has an extension on the lateral side. Okay. So here this is called as the saccule of the larynx, which is provided with numerous mucus gland, okay, which lubricates the vocal cord during phonation. And actually this is also otherwise called as oil can of larynx. Okay, so the saccule of larynx is otherwise called oil can of larynx. Okay. Now in the laryngeal cavity, you know, this anterior wall is longer than the posterior wall. Okay. Now this is again the image of the laryngeal cavity. It is opened on the thyroid lamina. Okay, you can see the folds here, vestibular fold and vocal fold. So this space here is the sinus of the larynx or ventricle of larynx. Okay. Now you know, the part of the laryngeal cavity above the vestibular fold is called as the vestibule. The part below the vocal fold here is called as the infraglottic compartment or glottis, infraglottic compartment. The above the vestibule fold, this vestibule or supraglottic compartment. So the sinus of larynx is otherwise called as glottis. Okay, now this compartment is the glottis. Now there will be a space between two vestibular fold here. This is called Rima vestibuli. And the space between the two vocal fold here is the Rima glottis. Okay. So in this session we are going to deal detailedly about the Rima vestibuli and glottis. Okay. So the Rima vestibuli, okay, so which is on either side bounded by the false vocal cord. Okay. So it is a space between the two vestibular fold. Okay. And this actually, if you see the each vestibular fold here will be lined by the mucous membrane, which is lined by ciliated columnar epithelium, and it consists of submucous areolar tissue beneath the mucous membrane, and you have the vestibular ligament. Okay, the vestibular fold consists of mucous membrane, which is lined by ciliated columnar epithelium. Underlying the epithelium, you have submucous areolar tissue. So next will be your ligament, vestibular ligament. You know how the vestibular ligament is formed. It is formed by the thickening of the lower free margin of the quadrate membrane. Okay. So if you see the functions of the Rima vestibuli are false vocal cord. Okay. So actually this permits air entry in inspiration. So in the inspiration, this Rima vestibuli allow the air to enter the glottis and infraglottic part. Okay. But if you see in expiration, it prevents the air exit in expiration. Okay. So therefore, it acts as an exit valve. Okay. And usually the holding of the breath at the end of the inspiration is mainly done by the portion of the vestibular fold. So this action is very essential. So whenever if there is any increase in intra-abdominal pressure, that is during coughing, micturition, defecation, or parturition in female, that time there should be approximation of the vestibular fold. This will increase the intra-abdominal pressure. Okay, so I think now you are clear about the Rima vestibuli. So Rima vestibuli is nothing but a space between the two vestibular fold. Okay, so it is lined by ciliated columnar epithelium underlying areolar tissue. The next will be the vestibular ligament. Okay, if you see the function, it prevents air entry in inspiration and prevents air exit in expiration. So it acts as an exit valve. Okay, it also helps in the holding of the breath at the end of inspiration. So which is done by the portion of the vestibular fold. Okay, so after inspiration, this vestibular fold approximate and closes the glottic part. Okay, so next we'll go on to the Rima glottidis. So Rima glottidis nothing but the space between the two vocal fold. Okay, so this is the superior view of the laryngeal cavity. You can see the thyroid cartilage here. Okay, and this is the arytenoid cartilage. You can see this is the cricoid cartilage. You can see the cricoid cartilage here, and this is the median cricothyroid ligament. And this is the vocal process which gives attachment to the vocal ligament. This is the vocal ligament here. Okay, and you can see this vocal ligament. Now actually the Rima glottidis is nothing but the narrowest anteroposterior cleft of the laryngeal cavity, which is longer in males, that is 23 millimeter in males, and females it is only about 17 millimeter. Okay, so this Rima glottidis is lined by non-keratinized stratified squamous epithelium. So epithelium differs in both Rima vestibuli and Rima glottidis. So it is lined by non-keratinized stratified squamous epithelium, and it is devoid of submucosal coat. But Rima vestibuli has submucosal areolar tissue. Here submucosal coat is absent. Okay. And if you see the boundaries of the Rima glottidis, it is anteriorly bounded by the angle of the thyroid cartilage, and posteriorly you have the interarytenoid mucus fold here. So on each side it is bounded by the vocal fold. Okay, so the boundaries of the Rima glottidis is anteriorly by the angle of thyroid cartilage, on either side by the vocal fold or vocal ligament, and behind by the interarytenoid fold of mucous membrane. Okay, now if you see the vocal fold in the anterior 3/5, it is made up of intermembranous part. That is, it is formed by vocal ligament. The posterior 2/5 is formed by the intercartilaginous part, that is the arytenoid cartilage. Okay, I think now you are clear about the Rima glottidis. So on each side, the anterior 3/5 of the boundary is formed by intermembranous part, that is vocal ligament, and posterior 2/5 is formed by the intercartilaginous part, that is formed by the arytenoid cartilage. Okay, so I think now you are clear with the Rima glottidis. Now we'll see what is vocal fold. Rima glottidis is different and vocal fold is different. So the space between the vocal fold here is called Rima glottidis. This you have to understand. Okay. So now we'll go on to the vocal fold or vocal cord. So the vocal ligament is covered by mucous membrane, that is called vocal fold or true vocal cord, which is pearly white in color and is lined by stratified squamous non-keratinized epithelium. As I already said, it is devoid of submucous tissue. And if you see the vocal fold, it consists of vocal ligament medially and vocalis muscle laterally. Okay, and the vocal ligament, you know, it is formed by the thickening of the upper pre-margin of cricovocal membrane. The other name for cricovocal membrane, you know, it is the conus elasticus. So this vocal fold extends from the tip of the vocal process to the angle of the thyroid cartilage. Okay. So with this picture, I think you are clear about the vocal fold. So vocal fold is different, Rima glottis is different. Okay, so if the vocal fold is asked, you have to write about this only, don't write about Rima glottis. Okay, now we'll go on to the functions of the Rima glottis. Okay, so what are the functions of the Rima? So at this point you have to remember the functions of the Rima vestibuli. So it allows air entry in inspiration and prevents air exit during expiration. So it acts as an exit valve. Okay, now if you see the function of the Rima glottis, it is opposite to the Rima vestibuli. Okay, so what is the opposite action? Okay, so it prevents air entry in inspiration. It allows air to exit in expiration. Okay, so it acts as an entry valve here. Okay, so that is the main function of the Rima glottis. So other than this, Rima glottis acts in phonation as a voice box. So the sound is mainly produced by the vibration of the vocal cord from the expired air from the lung. Okay, so that vibration is mainly produced by the expired air from the lung. Okay, and it is also the tone producing organ. The tone mainly depends on the length and degree of the tension of the vocal fold or vocal cord. Okay, so I think now you are clear about the functions of the Rima glottis. Now we'll see the shape of the Rima glottis during different movements of the vocal cord. Okay, so the first picture shows the shape of the Rima glottis in resting position. So that is in normal quiet breathing. If you are sitting simply, okay, without doing any activity. So in this part, if you see the shape of the Rima glottis, it is almost pentagonal in shape. Okay, so this intramembranous part is triangular and the intercartilaginous part is rectangular. So it appears pentagonal in shape. Okay, now if you see in case of forced inspiration, so in case of forced inspiration, the glottis widens here and it becomes diamond shape. Okay, it becomes diamond shape. So it is also otherwise you can tell the intermembranous part assume the enlarged triangular in shape. Okay, so in resting condition it appears pentagonal in shape. In forced inspiration it appears diamond in shape. Okay, so otherwise you can say enlarged triangular in shape during forced inspiration. Okay, so this is mainly done by the abduction of the vocal cord, that is done by the posterior cricoarytenoid muscle. Okay, so next we'll go on to the phonation. During phonation, that is in high pitched sound. Okay, in high pitched sound. So if you see what happened, actually the transverse arytenoid will act and even the oblique arytenoid. So they will adduct the vocal cord and this results in a shape called linear chink. Okay, so it causes adduction of both the intermembranous and intercartilaginous part. So this forms a shape called that is linear chink, or it is a median compression of the vocal cord. Okay, and during whispering, okay, in whispering what happened, the intermembranous part will be highly adducted and intercartilaginous part is separated. So now this appears as an inverted funnel shaped appearance. So during whispering, the Rima glottis appears in inverted funnel shape. Okay, so I think now you are clear. Once again, I am repeating. During resting condition, the Rima glottis appears pentagonal in shape. During forced inspiration, it appears diamond shaped or enlarged triangular in shape. During high-pitched sound or during phonation, it appears as a linear chunk. It is closely approximated with each other. And during whispering, it appears inverted funnel shape. Okay. So that's all about the Rima glottis. Next, we'll go on to the mucous membrane of the larynx. So actually the mucus, if you see the larynx, it is the mucous membrane is completely lined by ciliated columnar epithelium, except the following areas which are lined by stratified squamous non-keratinized. That is the area epiglottic fold, vocal fold, and upper part of the posterior surface of the epiglottis. So these three areas are covered by stratified squamous non-keratinized epithelium. Other areas are covered by ciliated columnar epithelium. It is not pseudostratified, it is ciliated columnar epithelium. It's a typing mistake here. Okay. So I think you're clear about the lining epithelium of the larynx. Okay. Why it is stratified squamous non-keratinized epithelium in the vocal fold? So this you can answer at the end of the class. You think an answer at the end of the class. Okay. So next we'll go on to the bus session. For this you can answer in the chat box. Okay. The shape of the Rima glottis during phonation. What is the shape? What is the shape during phonation? Okay. So during phonation, that is in high pitch sound, it appears linear chink. That is the answer for this question. Okay. So next question, all the muscles are attached to arytenoid cartilage except which muscle is not attached to the arytenoid cartilage? Yeah, all are very sharp. Okay. So the answer here is thyroepiglotticus. All other muscles are attached to the arytenoid cartilage. Okay. Okay, good. So with this, I'll continue on to the cadaveric image showing the inlet of the larynx. Okay. So you can see the airy epiglottic one fold in number 1. 2 is the epiglottis. Okay. So 3 is showing the oblique arytenoid, and again 3 transverse arytenoid, and 5 is the posterior cricoarytenoid, and 4 is the posterior border of the lamina of the thyroid cartilage. Okay. So we'll go on to the next nerve supply of the larynx. In the previous session, we have seen the motor nerve supply of the larynx. Now we are going to see about the sensory nerve supply of the larynx. Okay. So the sensory nerve supply of the larynx is divided into 2. That is where you take the vocal fold as a distinct point, and the part above the vocal fold is supplied by the internal laryngeal nerve, which is a branch of superior laryngeal nerve, and the part below the vocal fold is supplied by the recurrent laryngeal nerve. Okay, so this is sensory supply of the pharynx. So the sensory supply, that is mucous membrane of the larynx, is supplied above the vocal fold by the internal laryngeal nerve. This is a branch of superior laryngeal nerve, which in turn is a branch of vagus. And below the vocal fold, it is supplied by the recurrent laryngeal nerve, which in turn it is a branch of the vagus nerve. Okay. So now next we'll see about the arterial supply. For the arterial supply also, you have to take the landmark as vocal fold, and you have to read above the vocal fold and below the vocal fold. Okay. Now you can see this artery is the common carotid artery. This is the external carotid, internal carotid. External carotid, you can see the first branch giving here is the superior thyroid artery. This is the superior thyroid artery. Okay. And you can see from the thyrocervical trunk of the first part of subclavian artery, it gives inferior thyroid artery. This is the inferior thyroid artery. Okay. So this is subclavian artery. From the first part of subclavian artery, it gives thyrocervical trunk. So the thyrocervical trunk gives one branch, that is the inferior thyroid artery. Okay. Now see, above the vocal fold, the larynx is supplied by superior laryngeal artery, which in turn is a branch of superior thyroid artery. Okay. Then below the vocal fold, it is supplied by inferior laryngeal artery, which in turn is a branch of the inferior thyroid artery. Okay. So now the venous drainage is same. The artery is followed by vein. So the superior laryngeal vein, it follows the artery, but it drains into superior thyroid vein. Inferior laryngeal vein follows the inferior laryngeal artery, which drains into inferior thyroid vein. Okay. Now next we'll see about the lymphatic drainage. So here also above the vocal fold, it drains into upper deep cervical lymph node. This is anterosuperior group. So below the vocal fold, it drains into lower deep cervical node, or sometimes it will go to pretracheal and prelaryngeal lymph nodes. Okay. I think now you're clear about the lymphatic drainage of the larynx. Okay. So take the landmark as vocal fold. So above vocal fold, The arterial supplies superior laryngeal artery, superior laryngeal vein, lymphatic drainage goes to upper deep cervical lymph node. So below vocal fold, the artery is inferior laryngeal artery, vein is inferior laryngeal vein, and the node is the lower deep cervical node or pretracheal or pre-laryngeal lymph node. Okay, so the nerve supply above the vocal fold is the internal laryngeal nerve. The nerve supplied below the vocal fold is by the recurrent laryngeal nerve. Okay, now next we'll go on to the vocal cord anatomy in laryngoscopic view. So this is the laryngoscopic picture of the uh, inlet of larynx. Okay, so actually this is a indirect laryngoscope. So now you can see the epiglottis here, and this is the vocal fold. See, this is the vocal fold, this true vocal cord. The space here is the Rima glottidis. Inside you can see the trachea. So on either side you can see on mucous membrane, this is the false vocal cord or vestibular fold. And this is the area epiglottic fold. You can see the area epiglottic fold, and you can see the two cartilages here. This is the carniclate and cuneiform, and this fossa here is the pyriform fossa. Okay, this is a laryngoscopic view of the inlet of larynx. Okay, so with this we'll go on to the applied anatomy of the larynx. Okay, so the larynx can be viewed through the laryngoscope. There are two types of laryngoscopy, indirect and direct. So indirect, it requires laryngeal mirror. If you have gone to ENT/OP, if you are with any complaint of throat pain, they usually check with the laryngeal mirror to see the larynx. Okay, so actually with the help of laryngeal mirror and head mirror, you can see the inlet of larynx like this. So if you view this, you can see all the structures. What are the structures you can view in direct laryngoscopy? You can see the base of the tongue, median glossoepiglottic fold, and epiglottis you can see, and you can see the vocal cord, and you can see the sinus of larynx, vestibular fold also you can see the Rima glottidis, and even you can see the tracheal rings. So carniclate cartilage, cuneiform cartilage, all this you can view in the indirect laryngoscope. Okay, so usually the direct laryngoscope is for giving either for intubation, there is for endotracheal intubation, usually done under general anesthesia. Okay, so this is usually they will through actually inlet of larynx, so they will enter and they will put the endotracheal tube for artificial respiration. Okay, this is called direct laryngoscopy. Okay, so then next we'll see about the other applied aspects. Actually, singer's nodule or screamer's nodule, Kurgiman's nodules, teacher's nodule. So this is nothing but the vocal cord nodules, and that is mainly due to repeated use of the vocal cord result in increase in tension of the vocal cord, so which causes the vocal nodules. So this is mainly those who are overusing their voices. For them, it is more common. Okay, so for this condition, rest is the only treatment. Okay, with some anti-inflammatory. Okay, so this nodule is otherwise called teacher's nodule or singer's nodule. Okay, so next is the Rinke's edema. What is Rinke's edema? Edema of the vocal cord is called Rinke's edema. So this is mainly associated with smoking in females. Okay, so in females, usually the males, I think it will be adapted. For females, it is unusual. So there will be accumulation of the extracellular fluid and there will be swelling of the vocal cord. This results in edema called Rinke's edema. You can see in the next picture. You can see the edematous appearance of the vocal cord here. Okay. And next important applied aspect is the laryngeal obstruction. So you know above the vocal fold, the sensory supply of the larynx is by the internal laryngeal nerve. If the internal laryngeal nerve is damaged, okay, what happened? Okay, there will be anesthesia over the supraglottic portion. So this results in loss of protective cough reflex. What happened? Sometimes if you are drinking water or eating something, if it goes inside the larynx, means you will get a cough. Okay, so in case of internal laryngeal nerve damage, so this protective cough reflex will be lost. So as a result, the foreign bodies will easily enter the larynx. Okay, so this is more common in children. If for in comatose patient or in bedridden patient, in children it is usually more common laryngeal obstruction. So how will you immediately will bring out the foreign object from the larynx? If any, if in your home also, if anybody, if children is swallowing something and if it gets obstructed and they are gasping for breath, so you can do this procedure. This is called Heimlich maneuver. Okay, so you put your hand over the epigastrium. Okay, and keep your one hand over the other and give an upward and forward thrust over the epigastrium. So this will bring out the obstructed particle in the larynx. So if the foreign object is not coming out, then you have to get the medical help. Okay, so this is the immediate help you can do in the home. Okay, you can see the position of the hands. So this should be in the epigastric region. Okay, so next important applied aspect is the laryngocele. So you know, this is the saccule of the larynx, which is an extension from the sinus of larynx, which is filled with numerous mucus glands. Okay, sometimes, okay, if they are expired air is coming more from the lungs. Okay, so what happened? There will be blowing of the excess filling of the saccule of larynx, so which will go into the actually excess filling of the sinus of larynx, which will go into the saccule. So then the saccule will extend outside as a protrusion. This is called laryngocele. Okay, this is called as a laryngocele. This may be internal or it may be external. So laryngocele, nothing but a dilated sac of the saccule of larynx, which is seen either inside the thyroid lamina or it will sometimes will pierce the thyroid membrane. It will come out of the thyroid membrane. So this type of swelling is called external laryngocele. So this is more common in trumpet players, glass blowers, or weightlifters. Okay, so they will take a deep breath and their intra-abdominal pressure will be increased, and they will because of that there will be increased accumulation of air in the sinus. This will lead on to laryngocele. Okay, so this is a chronic condition. Okay, so next we'll go on to the laryngeal paralysis. This is more important. So this, if you if you see the classification of laryngeal paralysis, this is divided into unilateral or bilateral. So it may involve either recurrent laryngeal nerve or superior laryngeal nerve. Okay. So first we'll see unilateral damage of the recurrent laryngeal nerve. What happens if it is unilaterally damaged? The vocal cord on the affected side lies in paramedian position. That means it lies between abduction and adduction, and it does not vibrate. Okay, so this position of the vocal cord is called cadaveric position. If the vocal cord lies in paramedian position, then this position of the vocal cord is called cadaveric position. Usually, if one side vocal cord is not functioning, the other side vocal cord will compensate. So the patient will not have any symptoms. Some hoarseness of voice will be there, but the all other functions are compensated by the opposite vocal cord. Okay. Now you can see the here the paralysis of the recurrent laryngeal. Here also you can see left side is paralyzed, so it lies in paramedian position. Okay, so you will have only the hoarseness here. Okay, and if there is bilateral damage of the recurrent laryngeal nerve, then what happened? Okay, complete absence of phonation will be there, and the patient will gasp or breathe. Okay, so if it is not immediately treated, then patient will go for death. Okay, so for this, what they will do, no, they will do laryngectomy. Okay, so between thyroid and cricoid cartilage, that is a cricothyroid membrane, they will open it and put an tube over that, and they will create an additional airway. Okay, so this usually the bilateral damage will occur in case of during thyroid surgery. So while removing thyroid gland, accidentally they may remove the recurrent laryngeal or they may damage the recurrent laryngeal. So in this case, it will result. Okay. So even the unilateral damage also, this is because of the thyroid surgery only. Okay. So you can see the laryngotomy, the cricothyroid ligament membrane is open and additional airway will be established here. Okay. Now the inflammation of the larynx is called laryngitis. Okay. So this produces hoarseness of voice. Sometimes you can see the voice will be completely absent because of inflammation, and you can see how much the vocal cord is edematous here. It almost obstruct the airway here. So this is in chronic laryngitis it will happen. Okay. And another inflammation of the epiglottis is called epiglottitis. You can see in this picture how it is swollen. Okay, the epiglottis is swollen. This is because of the inflammation of the epiglottis. Okay. Now, next clinical anatomy is the malignancy of the larynx. It may be a supraglottic or glottic or subglottic. Okay. So with this, I'll finish the class. Okay. If you have any doubt, you can clear now. Okay.